Hi, welcome to PH Insights, presented by the Pulmonary Hypertension Association. Join us as we delve into patient stories, healthcare updates, and the latest insights on pulmonary hypertension. Thank you to our platform sponsor, J&J, for their unrestricted support of PH Insights. Sponsors do not endorse or participate in the development of program content.
Hello, welcome to PH Insights. My name is Navneet Singh, an assistant professor of medicine at Brown University and a pulmonary hypertension and pulmonary embolism physician at the Center for Advanced Lung Care at Brown University Health. And I'm really excited and honored to be invited today to lead today's episode on pulmonary embolism and chronic thromboembolic pulmonary hypertension, or CTEPH. And we're very excited to have with us today my friend and colleague, Dr. Chris Mullen, and I'll let him introduce himself.
Yeah, thanks, Navneet. I'm really excited to be here. My name is Chris Mullen. I am a physician and an assistant professor of medicine at Brown University. I am the associate director of our pulmonary hypertension program and the medical director of our CTEPH program at the Center for Advanced Lung Care at Brown University Health.
Great. And I have two disclaimers before we start. The first is that I invited Dr. Mullen to join me today under the guise that this was a podcast about the Bengals, because he's a huge Cincinnati Bengals fan. And surprise, Dr. Mullen, we're not going to talk about the Bengals. I'm sorry. I don't know anything about football, but you're welcome to go on and on about it if you'd like.
Not really the point of this podcast, even though I could fill up all the space here if that was so required.
All right. Well, folks listening, if you hear little tidbits about Bengals facts throughout the podcast, it's not my fault. So no, what we're really going to talk about today is what do people want to know if they get diagnosed with a pulmonary embolism, and what does that mean for them? And then we're going to talk about a rare condition called CTEPH and something that we deal with on a regular basis at our center. So I think we'll jump right into it. One of the things that I think a lot about is what people think about when they first get told that they have a pulmonary embolus. A lot of times this is when they're in the emergency room or they're in the hospital, and it can sound like a really scary thing, blood clots in your lungs. Chris, what are some things that you might first tell someone when they first get diagnosed with the pulmonary embolus?
Yeah, I think when I meet somebody in the hospital for the first time with a PE, it's usually a certain type of patient. It's usually a patient that is either in the emergency room or in the intensive care unit or on the medical floors with a pretty large amount of clot, and more of the sicker patients that we see in the hospital as in our job as intensivists and pulmonologists at a large tertiary academic medical center. So, the first thing I want when I meet someone with a PE is, I want to hear their story. I want to hear how they're feeling, kind of want to see how long things have been going on. In the back of my head, I'm rapidly assessing them to make sure that blood pressures are stable, their heart rates are stable, their oxygen's stable. Kind of after that, I do think it's really acknowledging that a PE is a pretty scary thing, right? We know that pulmonary embolism, or PE, acute PE, is the third leading cardiovascular cause of death in this country and the world, behind heart attack and stroke. And it's a serious diagnosis. Sometimes people with PEs have either had them before, or they know someone else in their family or a friend that's had them, and they may have an understanding of what someone else has been through. So I think it's important to hear what they're thinking and acknowledge that this is a scary diagnosis, one that is treatable, and a lot of things that we're going to talk about in the rest of this podcast, but it's a scary thing to go through as an individual.
That's great, Chris. Thank you. One of the first things I think people ask me a lot when I see them for the first time is how we made that diagnosis. And so probably the thing that comes to mind for most people is a CAT scan with contrast in the blood vessels, which actually shows the clot that's there. But there's a lot more to it, right? We look a lot at labs. We look a lot at imaging of the legs and the arms. So when you're first getting someone diagnosed with the PE, what are some other things you'd want to see and why?
Yeah, I think there's a lot of times when someone is diagnosed with a PE where it's pretty obvious, where the CAT scan shows a significant clot. There's no sort of gray area in the clot. It's clearly a PE. But there's sometimes when the diagnosis can be more challenging and more trickier. CAT scans and other tests are not perfect by any means. And so I think the first thing, taking a step back, if you meet someone with a PE, are you sure they have a PE? And again, most of the times it's clear, but it's not always the case. But then just because someone has a PE and they may have some of the typical symptoms for PE, like shortness of breath, chest pain, leg swelling or redness, particularly if the PE is associated with a blood clot in the leg or a DVT, deep venous thrombosis, we want to make sure that there's nothing else going on medically that could also be contributing to those symptoms. People can have PEs and heart attacks or strokes at the same time or have something else going on. So it's an important thing to make sure that everything that can be the patient's experiencing and their symptoms are explained by a PE.
Yeah, I think a lot of times people ask, I've been having this swelling in my legs for months, and could this have been part of it? Or I just came back from a trip. Is it possible that might have played into it? And so one of the things I know I talk a lot to patients about when they've been first diagnosed with a PE is what are some of the risk factors? And so there are some that we do know for sure are risk factors. So people who have recently had surgery and have been immobilized for some reason, especially with their limbs being immobilized, a common one, like someone who has a knee surgery and can't move their leg for some time. People with known active cancers. We know that's a risk factor for people, and so that makes it more likely for people to have a PE. Recent travel, interestingly, so I always found this interesting as someone who loves to travel. I always get a little bit nervous about this, but it's true. It's just a fact of what happens is long plane rides, long car rides. This can predispose people to PEs as well. And then there's some more rare things like diseases that predispose people to have clotting, if that's known to be an issue with a person or their family. And that's always something to think about as well. But I think one of the things that I often find discussing with the majority of patients is that really we often don't know why they had the blood clot. And that can be really disconcerting for a lot of people, is that we know that we can diagnose them with the blood clot, but we don't know why. And that's what I want most people to know, is that's just how it is for a lot of people. And we try our best to find a good reason. And if not, we just move forward and work on treating them and trying to make sure that they do.
Yeah, I think, Navneet, a lot of people think that PEs, or maybe they've heard about them or seen them on TV, that things come on all of a sudden and someone's leg's red and swollen, they get short of breath. But people can show up with days, weeks of symptoms that can be come and go or be stuttering. And I think, people say to me, I don't think this was a PE because I was been short of breath kind of gradually for a couple of weeks, but it certainly can be. And I think the PE has been historically labeled as the great masquerader, right? Meaning that it can show up in very different ways. And different people, different patients will respond, react, and have different symptoms than other people. And so it's very different for different people. And I think it's a big part of this is trying to individualize a diagnosis based on someone's symptoms, their risk factors, and other things. It's a great point.
Yeah. So let's talk about what happens when someone first gets diagnosed with a PE. So they're going to undergo a lot of tests. We talked about the CAT scan, and there's probably a lot of other things that are going to happen at the same time. Blood work to look at markers of possible clotting that's happening, ultrasounds to look for clots in other parts of the body, an ultrasound of the heart to see if there's been strain on the heart. And a lot of times we'll use that information plus things about if they're requiring oxygen, if their heart rate is elevated, their age and other risk factors to decide on what next. So where do they go from there? And there's probably a couple different scenarios. Some people will go home, which I think is shocking to some patients, that they'll get diagnosed with the pulmonary embolus in the emergency room and then get sent home, because it sounds like so scary. How could I possibly go home? But that is a pathway for a good number of people. People will get admitted to the hospital, to the regular medical wards, where they'll maybe see docs like us and get taken care of and then eventually get discharged. And then there's a smaller number of patients who end up in the intensive care unit for a number of reasons. So in your experience, what are some of the things you'd be looking for to reassure you about someone who just got diagnosed with a PE and you think is probably safe to go home?
Yeah, so I like the way you laid that out, Navneet. I think to put the more sort of medical sort of terms of what you're describing is something we would call risk stratification for acute PE. After a PE is diagnosed, we are trying to figure out how much at risk is a person. I think sometimes it's scary to talk about, but we're actually talking about risk of death. And that's not an easy thing for many patients, for many doctors to think about. And so what we're trying to identify are people who we think are at a higher risk of getting sicker or even dying from their PE. We know PEs can be fatal, unfortunately, and those who we think are able to go home. So to answer your question directly, the person who is going to be able to be discharged home is somebody for whom we think is at a low risk of getting sicker or decompensating or dying. And there are a couple different things that we can do to determine that. There are clinical scoring systems, so essentially tabulating points based on someone's age, their medical condition, some abnormalities in their vital signs, or their oxygen levels, their heart rate, that can tell us who is at a high risk or low risk. And so for people who are low risk, who don't have a lots amount of clots, whose right side of their heart is not under stress when we look at it on the CAT scan or by some of the blood tests, those are people that we think about, can this person go home with a blood thinner? Now, that requires the ability for someone to take a blood thinner, typically an oral blood thinner, and someone that we think is going to be able to take that medication safely and have close follow-up with an outpatient physician like a primary care doctor or somebody else. So those are some of the things that get thought about in that situation.
Right. And, that was a great summary. I think what's important that I took away from that is that people can go home safely with the PE. And I think it takes a lot of people to weigh in and help make that decision together. It's not just about what the doctors think. It's also about if the patient and the people who take care of the patient have the resources to really manage what comes next at home. And if that's not the case, then maybe the right decision is to get admitted to the hospital to talk about next steps. But I think it's reassuring that there are some people who will get diagnosed with the PE and be able to go home. So then there's the other extreme, right? So there are some people who will need to be admitted to the intensive care unit, and that's a decision that gets made as a group, with a group of a lot of specialists usually. There is that middle ground, which is people who maybe we don't feel like should go home right away, but maybe don't need the intensive care unit. And there's a lot of variety in that. But in my head, and what I think about and what I teach to people who are training in terms of who needs to come to the ICU, there's a pretty clear branch point in my head is, has there been strain on a person's heart from the PE that they've had? And that can be also a wide variety of people, right? So there can be people who've had some strain on a little bit of oxygen, but are doing really well, reading the newspaper, walking around. But then there's people who could be much sicker. And so that's the first step that I see. But there's probably a lot more granular stuff that go into that. Can you talk a little bit more about how you might approach that in a little bit more detail?
Yeah, I mean, I think everybody is different when they come with a PE, and it's really an individualized decision based on who that person is before they had the clot, with medical conditions and other things they had pre-existing, and then how they're responding to their acute PE. I think at the most extreme, which can be, I think, hard for some people and patients to hear about, is in people who are incredibly critically ill or have unstable blood pressure, unstable oxygenation, who really require a lot of support. Those are people that are definitely going to be going to an intensive care unit and definitely going to be exploring some reperfusion therapies, which is something that we're going to talk about a little bit later. I think in anybody who is showing evidence that the right side of their heart is under a lot of strain or stress from their blood clot, whether it's by their exam, by their vitals, by some blood test, those are people that we want to keep in the ICU for close monitoring and making sure we don't have to do reperfusion therapies more than just anticoagulation alone.
And a lot of times people will ask me, who's involved in making this decision? And it's different at every hospital, really. It's different for every person that walks in. Thinking about this because I was actually working in the ICU this weekend, and I was on call for our PE response team, which is also known as PERT, which you know very well because you direct that team. And you've grown this into a really wonderful system for us, for providers in the hospital and for patients to directly and very quickly access the experts that they need to answer the questions about what next. And so one nice thing about this system is that in hospitals where they have them, it's a direct line for people from the emergency room or the medical wards to reach the people who can talk about those advanced therapies like you just alluded to, and which we'll talk about in a few minutes more, reperfusion therapies, advanced types of medications to treat blood clots. And it's really nice because it gives us an opportunity to collaborate and make decisions as a team about patients' care. And so a typical scenario, which is for like what happened this weekend when I was working, was an emergency room physician diagnoses a patient with the blood clot. And they have the question, does this person need, one, to come to the ICU? And two, would they benefit from anything more than blood thinners? And so that's where we all get looped in. And here at our hospital, the way we have it set up is that the people who help make that decision are us, the pulmonologists and intensivists, the cardiologist and our interventional radiologists, and our cardiothoracic surgeons, all of whom can offer different types of interventions or treatment options and are all experts in treating pulmonary embolism in multiple different angles. And it's nice because we get to all have a conversation. We very quickly review the imaging any time of day or night, and we get to make a recommendation about what should happen next with the patient's care. As someone who's had a lot of experience with our PERT team, what are some of the advantages you've seen that we've been able to provide our patient population and with our providers that we work with since you started working on it?
Yeah, I don't really have a whole lot more to add than your nice summary there, Navneet. I think really the strength is having multiple physicians from different specialties to get together quickly, to talk and lend their perspectives from their respective specialty to help come up with a unified treatment plan for patients. I think that PERTs and PERT programs have sprung up in many hospitals across the country, across the world, certainly tend to be more common in large academic or tertiary medical centers, but plenty of other hospitals have them. And I think it really allows multidisciplinary collaboration in real time is the strength. And again, we do this because it really helps care for patients.
That's right. So we're going to talk about reperfusion therapy for a little while. So let's get into it. So one of the major decisions that the PERT team really is making is, does a person need reperfusion therapy or not? And I'll talk a little bit about some of the options, but I think one of the things that, you taught me and many people now I have gone on to teach is that this is a very nuanced decision. It has a lot to do with the person that you're talking about, the person who's been diagnosed with the pulmonary embolism, what you're trying to achieve, what your goals are, and also what the options are at your hospital in terms of expertise and technology. And what I've learned is that, there's one specific option that's the clear best option.
Yeah, I agree. For the vast majority of patients that are diagnosed with acute PE, systemic anticoagulation or blood thinners are the first line of therapies. And when people are admitted to the hospital, that usually is either intravenous or subcutaneous heparin-based products are the typical things. And then people get transitioned over to oral anticoagulants pretty quickly. Again, the people that are leaving from the emergency room therapy is the anticoagulation enough, or do we need to do something more to get rid of the clots or break the clots up? And the way that I explain it to patients is that blood thinners, oral anticoagulants, those don't burst or break up the clots. They prevent more clot from forming and extending from traveling into the lungs from elsewhere, and they allow the body to reabsorb the clot. That reabsorption process can be fast, can be slow, on the order of hours, days, weeks. And so what we're asking when someone is very sick or could be sick is, do we need to do more than just blood thinners and burst or break up the clots? And again, I kind of want to just emphasize your statements that this is an evolving field. There's many different things. Some places and hospitals are able to do certain things and not others. And so it's a very nuanced decision, like you said.
So when I think about it in three categories. There's that traditional clot buster medication that's been around for decades, since longer than I've been practicing. These are the clot busting medications that we put in, systemic thrombolytics. Then there's catheter-based procedures, which these are newer kids on the block, but these are minimally interventional procedures where catheters are used to do different things, either bust up clots or suck out the clots. And then there's surgery, where surgeons can actually go in and try to remove the clots more manually. So I'll start with just the first one. Systemic thrombolytics, or lytics as we often call them, really don't get used too often, thankfully. I think what we know about them is that for someone who's otherwise stable or doing well, it's really not necessary because, like you mentioned before, systemic anticoagulation with either oral medications or IV or subcutaneous medications really are quite effective at stabilizing clots and preventing new clots from forming. And so really we only use those in what I can think about as emergencies, when it looks like there's enough strain on the heart where the heart might stop because of the blood clot, or if the heart has already stopped because of what we suspect is the blood clot causing. And that can be pretty scary. But the good news is that in an intensive care unit, that's why you're there. We have these medications readily available. And the reason why we really only save them for these emergency situations is because they do come at risk for bleeding. And there are certain people in whom we wouldn't consider it safe for. So, for example, if a person had recently had bleeding in their brain for whatever reason, and then they come to us with a PE, we may not feel that it's safe to give them systemic thrombolytics, even if they are in an emergency setting, because it could cause worsening of bleeding in their brain. Thankfully, we don't have to make those decisions very often. We don't have to think about them, but that is an option that's out there if we ever need it. Now, catheter-based procedures are something that are newer on the block, and I think you probably have a lot more expertise in this than I do. Do you want to talk a little bit about some of the options that are available and some of the nuance that goes into deciding who gets these or doesn't?
Yeah, thanks, Navneet. I think that this is something that's really evolved over the last decade in terms of what can be done with a catheter-based procedure for an acute blood clot in the lungs. And I think it's a very sort of nuanced decision. And to be honest, what happens with patients that we think may need these really depends on what's available at our hospital, who's available at our hospital. And I think that's the case across the country and the world. I think I probably in my head, I think about sort of two different types of catheter-based procedures. One is a procedure that's called catheter-directed thrombolysis, where that clot-busting medication that you so nicely talked about, Navneet, is given in a lower dose directly into the blood vessels in the lungs close to the clots. The second type of catheter-based procedure is something called a mechanical thrombectomy, and these devices that can use suction or other sort of techniques to essentially remove or suck out the clot. And the advantages of those is that they don't give somebody a medication like a systemic thrombolytic that causes a high risk of bleeding. And so the data for some of these procedures, particularly the newer mechanical thrombectomy devices, is evolving. And so we're learning more about them week by week, year by year. I think our experience and my experience and what I think is reported by colleagues across the country and the world is that in the right person, they seem to very help in terms of stabilizing people when you remove a lot of clot. I think it is a jarring amount of clot that can be removed. The interventional doctors that do them that we work with, as you know, Navneet, will often show patients pictures of the clots that they've sucked out, and they come to us in the office and they're like, "Did you see that clot?" And we're like, yes, we did. And it made us nervous at the time that we're glad it's out. And so it can be very impressive results. And I think, again, who is the right person or the right patient to go for a catheter-based procedure is something that we debate every day amongst ourselves in the ICU, and that at national conferences, people get up and debate against each other. And so it's certainly an evolving field, but for the right person is something that can really lead to dramatic improvements quickly and in the short term, and we hope in the long term.
Yeah, I have to say, in my short time doing this, it's been remarkable to see how much better people can feel after one of these procedures. And it's just incredible to be able to give people that back.
Absolutely.
We're not the ones who do them, so I can't take credit for it, but it's really cool to see. And I'll say for anyone out there who wants to know a little insight into what doctors think about, one of the most gratifying parts about this is it's really satisfying to see all the clot that has been sucked out. So if you ever watch like pimple popper videos on YouTube or things like that, it's sometimes extremely satisfying to see what's come out. And I've just gotten a little insight into my psyche. I'll talk about quickly the last piece, which is thrombectomies. And neither of us are surgeons, so I don't think we'll go too much into detail on this. And again, thankfully, the vast majority of patients who are even in the ICU and even need something additional done beyond systemic anticoagulation will not need one of these procedures. But it is an option for centers where surgeons have the expertise to do this. And these are procedures where they can go in and manually peel out the clot. And like with the mechanical thrombectomy, remove it, but it happens in a different manner. And they can reach slightly different areas. The decision about who gets surgery versus who gets mechanical procedures often has to do with, can a person tolerate the surgery? Because it's a pretty big surgery. And it's often reserved for people who are particularly ill, but still well enough to tolerate that surgery. Thankfully, we don't really end up seeing a lot of people who need to go down this road.
I think it's worth mentioning with all these things is that these are not things that are available in every hospital and every center across the country and the world. And so I think the systemic thrombolytics, the clot busting medication, that medication is probably in most emergency rooms because it can be given for strokes and heart attacks in certain circumstances. And so obviously it exists there as well to give for PE. Catheter-based procedures or a cardiac surgery or remove clots or something that are not available everywhere. And so I think what happens and what we see a lot is that if emergency room doctors or ICU doctors, cardiologists, pulmonologists, radiologists at a different hospital think someone could potentially benefit from one of these more advanced reperfusion therapies, they'll often try to transfer patients to a center that has those capabilities. And I think we get a fair number of patients that get referred to our hospitals for evaluation for these procedures from other hospitals. And I think that's something that's really important to us and to me personally is that we are not just trying to care and offer the best care for patients with acute PEs in our hospitals, in our healthcare system, but really in the region. And most of colleagues that do similar things to you and I, Navneet, I think operate and feel the same way.
Absolutely. All right. So let's now move on to some outpatient considerations. So, let's just say everything's gone well. You've had whatever interventions you may have needed in the hospital and you're ready to go home. One of the first decisions that we are thinking about making as we're preparing someone to leave the hospital is what kind of blood thinner do they want to be on? I've been lucky enough to get trained and practice in an era where these novel oral anticoagulants have been available to people. And these are the pills that you mentioned before, apixaban, rivaroxaban. And they're great because they don't really require a lot of monitoring. They're typically well tolerated, and a large majority of people can be on them. But there are others, and there are reasons why we might choose them. Do you want to talk about some of the other ones?
Yeah, there are other situations where other oral anticoagulants can be used. I think the one that many people may have been the most familiar with is warfarin, because it's one of the oldest blood thinners around. It works on vitamin K, and it's a very effective anticoagulant, but it requires a lot of monitoring, and that requires blood tests or finger pricks pretty regularly when it's first started to make sure the levels are where they need to be within a therapeutic range. It also comes with some changes in terms of what diets you can eat and how much vitamin K containing foods, particularly green leafy vegetables, someone can take. There are some medical conditions for which that is the preferred anticoagulation over some of these other newer pills. But again, it's an individualized decision. There are subcutaneous injections of low molecular weight heparins that can be given in other nuanced situations as well, like pregnancy probably being the one that's the most common, and other situations where that might get used as well. Again, these are individualized decisions. It's primarily medical decisions that sort of drive the decisions for which blood thinners to be on. But a real life decision that we see with our patients is the cost. And sometimes some of the newer oral medications come with costs and copays that are prohibitive to patients. I think no one likes talking about that sometimes, about the cost of medications, but it's real life, and it's a consideration that we have to have. A person needs to be able to afford their medications, and so that comes into to play for some people as well.
That's true, and that's a pretty challenging part of medicine, I think, sometimes for us, is when we want to give someone a certain type of medication, but it's just unaffordable. And so I think we've gotten pretty good at doing some backflips around that and trying to find ways in. One way in that I think some patients are not aware of is that some of these medications, the companies that produce them actually provide either copay assistance or patient assistance programs where there may be a way to get assistance for the cost of it. And there are other grant mechanisms as well where people can try to find assistance in paying for the medication so that, one, they're not spending a large amount of their income on these medications, and two, they can consider themselves eligible. And so I think it's worth for those people who are maybe listening, who've maybe been prescribed these medications, but where cost is a burden, talking to your healthcare provider about if that's an option for you. And I'll say this, PHA has resources on their website for how people can find some of these programs to help afford some of these medications. And we'll put a link to those resources in the notes for this podcast. So related to anticoagulation, I think the number one question I get asked by people when we're talking about these medications is, how long do I need to take these medications for? Is this lifelong, or is this sort of a short-term thing, like I'm getting treated with antibiotics for an infection? And I found that's actually a much more challenging question to answer than I initially thought. In medical school, you talked about these two categories, what we call provoked or unprovoked PE. Provoked meaning that there's something that we were able to identify that caused it, and unprovoked meaning that we're not sure what caused it. And that people who have quote unquote unprovoked PEs have to be on blood thinners for life, and that people who have provoked PEs can be on blood thinners for as short as 3 months and then go off of them. But in the real world, it's not quite so black and white, right, Chris? What has your experience really been like?
Yeah, I think it can be a really nuanced decision for some people. For some patients, sometimes can be pretty straightforward. I think it's one of these decisions that I think the term shared decision making comes up, where it's a decision that I, doctor, am making in conjunction with my patient. I think it's something that I know you and I both do. Certainly our primary care doctors, hematologists, cardiologists, other vascular medicine specialists who may counsel patients about the duration of anticoagulation or how long to be blood thinners. And so it can be a really nuanced decision. Again, with the caveat that this is really something that's tailored to each individual person, individual case, is what I'm worried about is if we stop blood thinners, what's the risk of having another clot? And we know that people who have had clots that just come out of the blue, unprovoked or no transient risk factor for a clot, are people that are at a higher risk of having another clot. And for many people, most people in those situations, that risk of having another clot is higher than the risks of bleeding and the hassle of being on a blood thinner continuously. But that's not true for everybody. And so really it's what we're trying to factor in is what's the risk of having another blood clot if we stop the blood thinners versus bleeding and the hassle of staying on a blood thinner. On the flip side, for somebody who has had a clot with a transient risk factor, something like a surgery with general anesthesia for more than 30 or 40 minutes, then those are people for whom, if they've recovered from their surgery, then we would potentially think about stopping blood thinners. But again, it's a very nuanced decision, an individualized one.
That's exactly right. And as you're talking, I'm thinking about a patient I saw last week in our office who was a young person who had an acute PE, and we really couldn't understand why they had it. And the conversation that we had, it had been about 6 months of them on blood thinners at that point. And the question that got posed to me was, do I really need to be on this for life? And I think that's really hard, because if you're a young person who's talking about being on blood thinners for hopefully 60, 70, 80 years, we had talked a lot about what are the potential implications on that in 15 years, 20 years? What if you need a surgery in 10 years? What if you develop other complicating conditions that you're not even thinking about right now? And that's really hard. And, there was no easy answer. We did exactly that. We talked about it. We talked about what was important to that person, what their priorities were. We talked about all the different factors to weigh. And at the end of the day, we made a decision together that felt like it was the right one for that person. And I used my medical knowledge to help them make that decision. And so it'll be different for every person. And I think one important thing is that the conversation would probably be different with me than it would be with you, because we're just going to talk about different things and different factors might come up. And there's no one right answer for a lot of people.
Yeah, I agree. And I think a lot of times what I tell my patients when we're talking about remaining on blood thinners after a clot is I use the word indefinite more than lifelong. And it's a subtle difference, but lifelong means that we're making a decision now that my patient's going to be on blood thinners for the rest of their life. And that's not, like you said, that's not always the case. And so I think indefinite is maybe a better word, or one that I like better, because it implies that we're going to keep going, but we're going to keep reassessing whether the risks or benefits remain the way they are, particularly because in 5, 10, 20 years, the data, and we have more different evidence or different studies that may help make a more informed decision. I like indefinite more than lifelong if I'm thinking about telling someone that we should, or recommending that we should stay on blood thinners.
That's a good way of framing that. I like that. You raised an interesting point just a few minutes ago. So you were talking a lot about other providers that would be involved in a patient's care after they go home with a PE. So this can include anyone from a primary care provider to a lung doctor, a pulmonologist like us, a cardiologist or a pulmonologist who specializes in post-pulmonary embolism, post-PE, pulmonary hypertension, and a hematologist or a blood specialist. In my perspective, I feel like the primary care is really the center of all of that, right? They're, to use a Bengals term, the quarterback of the process here. But obviously, we all work together to help each other out. And what do you see as your role in that team when a person comes to you after a PE?
Yeah, you and I both see a lot of patients after they've been admitted and discharged from the hospital with a blood clot. And so I think I agree with you that the primary care physician should be the ones helping make sure all the patient's needs are met. But I think what I can add to the care is really focusing on that duration, the question about duration of blood thinners, which is a big one, understandably, some primary care doctors are looking for a specialist like us to help the patient make the decision. And then I focus a lot on things like symptomatic recovery. And then the third thing is some other things that I think about in the background. So, I think the symptomatic recovery is one that I think about a lot, is asking 3-6 months after a clot, are you back to where you were before all this? A lot of times before I can even get that question out, patients will ask me, are the clots still there? I want to know. And I think those two kind of go hand in hand. And what we know is that people after having a PE can be short of breath, or they cannot recover. Some people bounce back quickly. Some people take a long time to recover, weeks or in months. And every person is different. And I think evaluating shortness of breath or issues with exercise intolerance or just not feeling recovered after PE can be a tricky thing and can be a nuanced thing, because some people are more short of breath because they get a little deconditioned because they weren't understandably as active as they were after the first few weeks or months after their PE than they were in the weeks or months preceding. But there are some people that have chronic or unresolved blood clots in the lungs, and that's not something that I want to miss, because there are things we can potentially do to make people better. But then also people can have a PE and then be short of breath or not able to do what they were able to do before, and it's for a different reason, like their asthma, their COPD, or their heart having an issue as well. So there's plenty of things that we think about when someone's short of breath after a PE. But again, the thing that we don't want to miss is chronic or unresolved blood clots.
Yeah, it's a great framework. So at our center, we see people with certain types of blood clots pretty routinely a few months after they've been discharged. And it's almost like a screening process. We want to make sure that we are screening our population for these rare diseases like CTEPH, which we'll talk about in a few minutes. But a lot of times, the majority of people who we're seeing, they don't actually have that condition. And like you said, it's a lot of investigation of understanding why have you not returned back to your baseline. And what I tell people when I meet them the first time after a blood clot is that there's probably one of three things that are going to happen. You're going to tell me you feel like $1 million. We have a good plan about what you need to do, and you've got a great team taking care of you, and we don't need to keep seeing each other. You don't need an extra doctor on your team, and that's great. And then there are some people who we may start to get suspicious about CTEPH or chronic blood clots causing strain on the heart and high blood pressures or pulmonary hypertension. And that's a whole different pathway. And that's, what we kind of really specialize in here at the Center for Advanced Lung Care. And then there's a third group, which is kind of like a bit of a grab bag. We sort of don't believe it's related to chronic blood clots, but they still don't feel like they're back to where they were before they had that blood clot. And like you said, that can be a lot of different things: asthma, COPD, sleep apnea, a lot of other things going on. But the nice thing is that coming to a lung doctor, pulmonologist like us, we have the skills to start helping them with those things too. And so that's kind of nice. We get to think about how do we help people feel less short of breath for other reasons.
Yeah. But I think, Navneet, sorry to interrupt you there. I think we as pulmonologists focus a lot on the lungs, and understandably so. The other thing that's always in the back of my head is making sure that we're not missing some yet undiagnosed cause of clots. And so I think you mentioned earlier in the podcast about cancer being a risk factor for clots. And it's not something that we routinely go looking for and trying to turn over every stone. But our typical recommendation for people is, one, to make sure that they are have up to date and completing their, we call age-appropriate cancer screening. So mammograms, colonoscopies, and things like that, lung cancer screening. And then also, and this is where primary care doctors probably are better than we are, of just running through all someone's symptoms. And if someone has a change in their weight or their stool or something else, then that can prompt an appropriate evaluation to make sure that blood clot wasn't the first sort of sign of potentially a cancer somewhere. Again, it's not terribly common, and it's not the typical course for people, but something that is always in the back of our heads as well.
Yeah, a lot of times, again, like you said before, people are really curious to know if the blood clots are gone or not. And that's really interesting. But what we know is that a lot of these blood clots that happen, some of them we can see on the CAT scan because they're in the larger blood vessels, but a lot of them that are actually causing the symptoms or that happened when they had the acute event are much further out in the lungs in the very tiny blood vessels. And those are things that we can't really see with a CAT scan. And so getting repeat chest imaging is not really part of the routine of what I do, at least, because it's not often going to find much that's going to change what we do, even though we often are curious to know what might have changed or didn't. But a lot of times the next set of tests have to do with general things that any pulmonologist or any physician or clinician who's working on shortness of breath might do. So these are things like pulmonary function tests, just to see what your lung function is. And is that giving us any clues as to why a person might be short of breath? We might do something called a 6-minute walk test, which gives us an idea of a person's functional capacity. So how far they can walk in 6 minutes, what their blood pressure does, what their oxygen levels are, like a mini stress test. And then there's more advanced stress tests that we can do to assess what someone's exercise capacity is. And there's different forms of that are out there. A common one that we hear about is CPET, or cardiopulmonary exercise test. And this is an involved exam that we don't have to go into today, but it generally involves something like being on a bike with a bunch of stuff hooked up to you and measuring your heart, your lungs, and your blood vessels and how they respond to exercise. There's another form of that, which is called a shape test. We do that in our clinic, which is nice, at the Center for Advanced Lung Care, which gives us a lot of that same information with a much simpler format. And that's been a nice addition to our center to get that information. But a big piece of this is who should get an echocardiogram after a pulmonary embolism. So how do you make that decision? When someone comes to you short of breath several months after a PE, how do you decide if someone should have their heart looked at with an echocardiogram?
Yeah, I think in general, for all the testing after a PE, one of the things I think about is I don't want to do a test unless it's going to change what I'm going to do for the patient or change the recommendations or change the treatment plan. And I think if somebody has had an acute PE and they're recovered, how much testing do I want to do? There's not an obvious answer there. However, I think if someone at the diagnosis of their PE had a lot of strain or dilation, enlargement of the right side of their heart, then those are people for whom I'm going to think about, should we do another echocardiogram to make sure that looks better, it's not still dilated, or there's not still an estimate of high pressure in the lungs. I don't do that for everybody, but it's a discussion and consideration that I have with my patient. But certainly I think if someone has shortness of breath or they haven't recovered at 3 or more months after a clot and they had the right side of their heart was under strain or stress at the time of their acute PE, then those are people who I will think about getting an echocardiogram and to take a look at the heart again. And in conjunction with sort of the decision about should I do another scan, whether it's another CT pulmonary angiogram scan to look for the blood clots in the lungs, or a ventilation perfusion scan or VQ scan to look for residual occlusions in the lungs after a clot as well. So these, again, really individualized to how someone's doing, but some of the tests that I think about doing kind of in conjunction with a lot of the stuff that you mentioned earlier.
All right. That's a great summary, Chris. So how often do people's clots not resolve? So sometimes we know that these acute blood clots are actually part of a larger process that can be caused by a lot of different things. What have you seen, and how often does that really happen?
Yeah, it's a hard number to answer. I think it's different depending on which different studies you look at. I will say that the majority of people that have acute blood clots, those clots resolve with blood thinner and times on anticoagulation, but not everybody. And so there are a percentage of people, again, it's a minority, where the clots don't resolve. And there's a percentage of those people that the clots don't resolve and they're left with residual high pressures in the lungs from chronic or unresolved blood clots. And that's this condition, chronic thromboembolic pulmonary hypertension, or CTEPH, which we've mentioned here a couple of times. And essentially we make that diagnosis when the pressure is high in the lungs, when we measure it directly with a catheterization, and imaging of the lungs shows evidence of chronic blood clots that are enough to cause that high pressure. It can be a challenging assessment to make, but it's one that we do. And then we typically have to have that done after at least 3 months of effective anticoagulation. So there are some people with CTEPH that show up and they've never had a blood clot before in their lives, and we figure out that they have CTEPH. And there are some people that have blood clots where they don't recover, and we find evidence of chronic or unresolved blood clots. What percentage of people with an acute blood clot will go on to develop CTEPH? You can look at different studies and get different estimates, anywhere from about 0.5%, even up to 8, 9, 10%. It's probably somewhere within that range. So again, it's a small minority of all comers with an acute PE.
Yeah, and there are some people who will never even have known that they've had a blood clot, right?
Exactly.
Who have CTEPH. So people come to us, to our pulmonary hypertension clinic, being worked up for general causes of pulmonary hypertension. And along the way, we do one of these scans or angiograms and find out that this is actually being caused by unresolved blood clots. And they've never even known that they've had a blood clot. And that can be disconcerting. But the nice thing is that it's a condition that we're actually learning a lot about as years go on. It's one of the forms of pulmonary hypertension for which, even in the short time that I've been practicing, I feel like I've seen a lot of advances. And it's a really exciting time for CTEPH. So I'll take a step back a little bit, pathway to the diagnosis. So you mentioned a catheterization, And what does that really involve? What are we looking for there?
Yeah, when I'm thinking about making a diagnosis of CTEPH or of pulmonary hypertension in general, that involves a procedure called a right heart catheterization, which is putting essentially a large IV into a vein, either in the neck or in the groin or in the arm. And through that IV, putting a tube into the right side of the heart and through the right side of the heart into the lungs and measuring the pressure. We do sometimes in the ICU. We do sometimes in the cardiac catheterization laboratory. And then we do when we're concerned about pulmonary hypertension in general and for CTEPH. If we're concerned about CTEPH, we will also, at the time of a right heart catheterization, do a procedure called a pulmonary angiogram, which is a direct injection of contrast directly into the pulmonary arteries to image the blood vessel of the lungs and look for where the clots are, for chronic or unresolved clots. And those are things that we think about doing, typically because it's an invasive procedure. The last step in many cases before all of the less invasive or non-invasive diagnostics, echoes and scans and pulmonary function tests and all those other things that we've talked about here for the last 5 minutes. Who do we send that for? Again, that's a very individualized and nuanced question. I think that in somebody who has shortness of breath after a PE, who has a scan that shows that there may be some chronic blood clot, particularly if their echocardiogram suggests that their pressures could be behind the lungs, then those are people that I'll think about sending on or doing those invasive diagnostics on.
Yeah, and when I think about what do we do with that information, it's funny because I feel like it's really parallel to the PERT team, the PE response team, and what happens when someone first comes into the hospital with that diagnosis. Here at our center, we have a multidisciplinary group of people that meets once a month to talk about the people that we think might have CTEPH or we know have CTEPH, and we talk about what are the factors that go into that diagnosis. And again, it's pulmonologists, cardiologists, radiologists, and surgeons who we all meet and give our opinions about what's going on. And then we talk about treatment options, which again fall into the same pattern as when someone's in the intensive care unit and needs an intervention. And it falls into medical therapy, there's catheter-based therapy, and then surgery. And it's kind of funny that it all comes in line. Now, you've been running our CTEPH program for a little while now and also coordinate our multidisciplinary meetings. Can you talk a little bit more about what that looks like?
Yeah, it is interesting that there are some parallels in the sort of the acute PE multidisciplinary stuff and the chronic PE stuff. I never thought about it that explicitly together, but they definitely feel very similar. I think that when we're thinking about doing invasive procedures and doing testing to look for or diagnose CTEPH, it's not just enough to make the diagnosis with my information and diagnostic procedures. It's making the diagnosis and trying to figure out what the best treatment can be. And so I think that really requires the expertise of us as pulmonologists and pulmonary hypertension specialists, cardiologists, interventional radiologists, cardiac surgeons that we work with to come up with the best individualized treatment plan for somebody. What we know is that people who have CTEPH, one of the things that we're trying to figure out in broad strokes that I explained to patients is whether or not they would be candidates to potentially have surgery to remove those chronic clots. And I think we talked about cardiac surgery earlier in the episode for acute PE. Cardiac surgery for CTEPH is a much more nuanced and a much more specialized procedure. It's a more delicate procedure. It's called the pulmonary endarterectomy, or some places call it a pulmonary thromboembolic. And that involves cardiac surgery with cardiac bypass to be able to slow and stop the heart so that the surgeon can remove delicately clots that have been chronically occluding the blood vessels. Certainly a big deal, but it's the sort of the most tried and true treatment for CTEPH. It's been around for decades. The surgery is pioneered out at the University of California, San Diego, and it's disseminated around the world. Think about people need to be able to tolerate and get through cardiac surgery because there are other medical issues. Then we have to think that the clots are central or big enough that we can remove them. And again, that's a very sort of nuanced, individualized decisions that different doctors and surgeons can disagree about whether a disease is surgical or not. For people who we don't think surgery makes sense for whatever reason, then a combination of medical therapies, oral pills, plus a procedure called a balloon pulmonary angioplasty, which is a catheter-based procedure, may be an option. Balloon pulmonary angioplasties are sort of, again, similar catheterizations that we use from the diagnostic standpoint, but these are multiple procedures that are staged over, one every few weeks over the course of weeks or months to gradually break up or open up some of the more chronically occluded smaller blood vessels in the lungs. Again, it's a very nuanced procedure that's only done in sort of handfuls of centers across the country and across the world. It is growing in the last sort of decade after the procedure is really in the current era, the modern era of the procedure. But it's something that for certain and for the right patient can be incredibly beneficial.
Yeah, and the last part of that is the medical therapies. And this is particularly exciting for me. My research is in the cells that line the blood vessels of the lungs. And I find it fascinating that we're starting to make more and more advances in our understanding of medical therapies that help to potentially relax the blood vessels, lower the blood pressures, and maybe even help heal them. And there's one standard medication that's kind of the first line therapy for people who need it. And it's a medication that's taken typically 3 times a day. And the goal is to lower the blood pressures inside the lungs to reduce the strain on the heart. And what's really cool is that what we've found is that it can be used sometimes alone in the right person to treat CTEPH. Even if we don't feel that they're a candidate for one of these procedures. But it can also be used in conjunction with these procedures before and after. And there's a small number of people who will need to be on these medications after. Those decisions, again, are quite nuanced. I think that's our favorite word. That's your key word for today, kids. But who should be on the medications when, for how long, in conjunction with the procedure or not, is an individualized discussion with your provider. But there are newer studies that are looking at other options to treat pulmonary hypertension from chronic blood clots or CTEPH. And so I'm hopeful that in the next few years or so, we have even more options for people. And I think one of the coolest things about CTEPH that when I learned about it is that it's the only form of pulmonary hypertension that we know of now that has a cure. Isn't that right, Chris?
Yes, and it's one of the only forms of PH that has the potential for cure. And again, sometimes that requires a large cardiac surgery. And so it's not a walk in the park by any means for people, but it is a disease for which there are great treatments that can be curative for some people. I think it's also worth pointing out over the course of this podcast, Navneet, is we've gone from acute PE to CTEPH. We've gone from something that is incredibly common that most lay people have heard of to something that's pretty exceedingly rare that many people have never heard of before. And so it's just important to point out for any of the individuals or people listening on this call that may have CTEPH or may think they have CTEPH is that this can be a tricky diagnosis to make. And so I think it's something that typically would recommend if you're short of breath after a PE of asking to see a pulmonologist. And if there's anything that's concerned for chronic blood clots, it makes sense to get referred to a center that can adequately work that up. If it's not a CTEPH center, then one that's accredited by the PHA for a pulmonary hypertension center.
Well, that's great. Thanks, Chris. This has been a lot of fun. Thanks so much for chatting with me about PE and CTEPH. This has been a really great experience, especially as someone who's part of the Patient and Caregiver Education Committee as on the Pulmonary Hypertension Association. This is a really fun part of what we get to do in terms of helping provide educational content for people living with pulmonary hypertension and their caregivers. So thanks for joining us today. Again, a reminder, as with every episode, the word of the day for us is nuance. And so please remember, we recommend that you discuss these topics that you heard today with your healthcare provider. But have a great one and have a good day.
And thank you for listening to PH Insights presented by the Pulmonary Hypertension Association. Remember to subscribe and to join us every second and fourth Wednesday of the month for more valuable insights. And thank you to J&J for their unrestricted support of PH Insights.